Danny, stand on. Okay. Let me fix back here. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. You're gonna have to move back here.
One, two, three, four, five. 1, 2, 3, 4, 5. So is it? Are we going through that one or are we going through this? Yeah, both fantastic. 1, 2, 3, 4, 5. Perfect. Is Danny? Is this interfering with it? Is that interfering? Is that interfering? So we've got 28 centres around the country linking in. Just to let you know. Well, they are linked in. Well, they're all telling me that they hear us. They can now. You have to put this on.
Okay, folks. How are we all doing? Good evening, everybody. Merry Christmas, everyone. Congratulations. Cheers. To the baby, Kevin Gill. You're all very welcome to our December night of OBI CPC nights, streaming live to 28 centres around the country at the moment, and getting bigger, so we're delighted. Currently on the screen you can just see it's a video that was done last year from the EMS gathering. Mark Forrest and the attack team, Jason Vanderbilt and a couple of other guys who were down there, put on a great show. So we just let it play while you were waiting to come in. And the one prior to that then was the CFO Ireland about the pit stop CPR. Andy O'Toole, AP with National Ambulance Service in Loughlinstown, just put the demonstration of pit stop CPR. The reason I put those up was because we have a large amount of CFR groups involved with the OBI CPC nights. So the whole point behind FOMED and the inspiration behind CPC nights was the fact that we bring everybody together, no matter what uniform you wear, no matter who pays your wages, no matter if you're voluntary, community, whatever, you learn something, and we pitch these nights at every level that we can to keep everybody informed of what's going on. So with that being said, I'd like to welcome you all tonight to our, this one here. Okay.
Try it.
Yeah.
Can you hear that now?
Can you hear that?
Yeah.
Good.
So we're good to go then on. So now we're live. Excellent. So you're all very, very welcome. Sign-in sheets on the end of the table. I made a cock up and Grania bet the head off when I went home the last night because I never got sign-in sheets for Dublin. So make sure you sign in at some stage. There's about 9 of them, 8 or 9 sheets going around the room tonight. Okay. So to start with,
is that why you didn't get a cert?
Yes, that's why I didn't get a cert. No, that's not the reason.
Well, Brandy got one and I didn't.
Yeah, but there's a reason for that. So
I'm only a pal.
yeah. Couple of great speakers tonight. Again, I can never forget to mention Grania Ryan, who facilitates down in Clonmel in the IT centre down there, so she never gets a chance to get to Dublin. She is the backbone of everything. She's the one that answers the emails, even though it says Glenn Ellis at the end of the email. Grania answers the emails. She's the one that does all the registration. She's the one that looks after the administration of the whole thing. So without her, this wouldn't be happening either. And that's Grania there on the left, where that's Danny on the right. Danny's our cameraman. For those of you who don't know Danny up the back, Danny Slevin. Brandman is his company, who do a lot of YouTube videos and other bits and pieces. Again, both Grania and Danny and myself do this all in our spare time, give up our free time to basically put these nights together. So we're very grateful to you guys for making these things happen, and I think you guys will be very grateful to Grania as well for the work that she does in the background also. So That's to Danny and Grania. I always have to start the show with that, otherwise I get in trouble. Some other bits and pieces I like to point out most nights. EMS Gathering is coming back in 2017. We're delighted to hear it's back. They've changed it now, it's going to Kinsale. It's from the 3rd to the 5th of May 2017. I strongly recommend it to any pre-hospital care people, no matter what level you're at. The quality of speakers we've had down there in the last couple of years has been fantastic, and it's growing. It's getting better and better and better. So last year with the simulations on the farm, simulation by attack, there was great feedback from that as well, and everybody really, really liked that. Some top international speakers are now looking on the circuit to come to Ireland and speak at this particular conference. So if you're available, don't miss out. It has a unique method of learning, i.e. you do learning through leisure. So there's about 8 different things happen on a day where you can go out on a trail, you can go on a bus, you can go on a boat, you can go on a bike, you can just sit in the classroom if you want, and you'll learn through the specialists that are actually giving you talks on the night then as well. So it's an excellent place to go if you're available the 3rd to the 5th of May. I'd also like to point out the 2nd edition, which is brilliant, of the Irish Journal of Paramedicine. Alan Batt, who's an expat, well not an expat, but he's an Irish lad who's currently out in Canada at the moment and doing really, really good pre-hospital care research around the world, and is flying the flag for Ireland. Alan was an advanced paramedic in Limerick, I think it was, and he's doing some great work, and this is his publication basically, and it's for us. This is a publication for pre-hospital care basically, and it's some of the projects involved in it, some of the articles, some of the papers in it are all done by paramedics, advanced paramedics, so it's a really, really good, and it's free. So if you go on to www.irishparamedicine, or even just Google the Irish Journal of Paramedicine, you'll go to his website and you can download the issue for free, and you'll get to read what your colleagues are doing around the country as well, and around the world. He's currently out in Turkey at the moment, Alan is at the International Expo for Paramedicine out there. That's where he is at the moment. Now, some other people I need to mention. EMS Nation, would you believe, should be tuning in tonight from New York. That's Fazzy. Fazzy was down, I met Fazzy, yourself and Gordon met Fazzy down at the SMAC conference last year, and he's really, really good. He's got one of his podcasts was done at SMAC and was also done at the Gathering last year. So he's a good, if you're into podcasts and you like some interesting pre-hospital stuff, if you look up EMS Nation, it's completely free as well. There's some excellent articles, excellent pieces from him, and his website is pretty good to look around as well. For those of you who had the opportunity to experience SMAC Dub last year, or this year should I say, it was unbelievable, and thanks to certain people in this room, those of us who couldn't make it got to see it. For some reason their phone was able to use Periscope and nobody else's was in the whole theatre, but for us that couldn't make the first day, it was absolutely fantastic to see it being streamed through a phone, and we got to see via Periscope a lot of the stuff that was happening in SMAC. So DAS SMAC is this year in Germany. It's basically SMAC is part of FOAMed. FOAMed was coined at the Emergency Services Conference here in Dublin. Was 2012 I think it was, and it was basically a couple of guys over a pint in the Ferryman pub decided to come up with this name called FOAMed after looking at the head of a pint of Guinness: free open access medical education. On the back of that, that's why the community of foam has evolved and is growing and growing and growing. Would you believe that SMAC generally sells out within 24 to 48 hours, and the tickets are expensive. But for those of you who won't be able to make it because it's dear, if you follow, just look up and you'll be able to follow their tweets, their periscopes and everything else to go along. Dub, which again put Ireland on a map of international EMS, was the piece they done down in the DCU centre, where they done a scenario, and it's on video, you can actually look it up, where the guards were involved and they done a mass casualty, a mass shooter basically incident down there, and it was scary to watch. It was absolutely scary to watch. But the Irish guys put a great show on, and some great people involved in it. So SMAC, another one to look out for if you can. And the last thing I want to talk to you about is this is Flight Bridge ED. A friend of mine, Eric Bauer, that's his podcast, is Flight Bridge ED. He does paediatric drowning, he does some paediatric emergencies, and again, some great podcasts for you. I find he's very good. Eric is about 30 years as a flight paramedic, and he's now stepped up in he's after getting promotion in his job. He's out of Kentucky, so he's getting a big promotion. Eric is going to be joining us in April to give a night's talk in April. and he's very, very good. So hopefully we get it on the gathering as well. So Floydbridge ED, after tonight, because we're just in the class 1 master classes of the paediatrics, do look in at Eric, Floydbridge ED, have a look at his podcast and have a look at the series, paediatric learning series. As per usual, the hashtag is OBICPC. I'll be manning the Twitter machine. Gron, you'll be doing it as well. And so if you have any questions that aren't answered here in the audience, please tweet us. If you have a question that we didn't get a chance to you didn't get a chance to ask, or in the centres around Ireland you didn't get answered, please email them to us and we will pass them on to the speakers as well. Okay? So if your question wasn't answered tonight or you have any queries, if you email it to us, so it's cpcnights@gmail.com, and we will answer, come back to you. But if you're doing anything or you're tweeting any pictures, please use the hashtag OBICPC. Okay? And we welcome all questions. So without further ado, and to get us started, I honestly can't believe we have the first speaker with us tonight. I really, really can't. It's unreal. For those of you who know him, he is a genuine man. He is a man. And he's very genuine, very humble. And he is one of those approachable people you knew when you walked into his emergency department, you could actually talk to him on a one-to-one level. The man is so famous they put his faces on the door handles within St. James's Hospital. That's how famous our first speaker is. Nobody else gets to do that, you know, so it's unbelievable. So I'd like you all to give a warm welcome, put your hands together, Professor Patrick Plunkett, formerly the
I've just pushed it the other way. See? He didn't tell me I was going to have to speak to the audience. He just sort of gave me the idea that I'd come and answer a couple of questions if I had to. And as for the face on the door,
I like that.
So is the porters, so is the cleaners. So, you know,
On all the doors?
not all the doors. Everybody sort of, there's about 8 of them. What do you want me to say?
So, when I thought of asking you to come and speak, okay, I said, who would I get to give us pearls of wisdom with regards to emergency care of the patient, care of the patient? Who will tell us the pitfalls that he has learned or she has learned over the years of medicine, so we can learn from them, so we don't make the same mistakes, and help to lead us to look after our patients appropriately, differently, but again, look after them as patients. Your community is a growing. Your community was a growing community, age-wise, demographically.
Well, it is.
The age profile of patients in that area is growing, and it's funny actually that this week they launched a specific training course in the States called GEMS, which is primary towards geriatric care, because that group of patients are unique in the problems that they have, and our own communities are growing age-wise. So a lot of people like the Gucci trauma, the TXA, the pelvic boilers, you know, let's intubate, let's do the great things. All of those things play a part in our job, but the age profile of patients, they can dictate how we treat our patients. So from a James's perspective, you have to tell us, how do we do it? Over to you.
I don't know how you do it. What I will tell you is you better learn how to do it fast, because in the next 13 years the population in this country over the age of 85 will more than double. It will increase by about 136%. The population over 65 won't quite double, it'll only increase by 86%. That will definitely include me and Shay.
God, you're right, I will get over 85.
I was talking about the over 65 bit. What problems do they have? What do I see? Where do we go with it? One of the biggest problems, as far as I'm concerned, is the fact that a lot of people have come to the natural end of their life, and we get extremely aggressive about interfering with that. And I think that's sort of thrust upon us to a certain extent because of the lack of legislative support for advance directives in this community, in this jurisdiction. And I think that's coming. I mean, the Capacity Act is now in. I think there's going to be an increased approach to letting people take a decision that they don't want to go any further and they don't want the bloody paramedics jumping on their chest. And I think most of you will have been involved in situations where you felt this is going a little bit too far over the edge. And certainly, if somebody comes in to me who's elderly, who's had an unwitnessed arrest, and who is in a systole, as far as I'm concerned, he's dead. And it won't take me very long to let the paramedics know that. But I'll do so in a polite way, because I don't think you've got much choice at the moment but to try and resuscitate. Beyond that, the vast majority of them will have sepsis of some sort, respiratory or urinary tract. And what can you do about that? Not a heck of a lot, except maybe give some fluid. Some will have stroke. The most important thing is to recognise it and get moving to a place that can deal with it. And they still have acute myocardial infarction that is amenable to going to the cath lab, even if they are at an advanced age. What more can I say? Trauma. They fall over and break their hips, or do they? They actually break their hips and fall over. They've got poor bone stock. But if you are aged 85 and you break your hip and you come into hospital, your prospect of survival and getting home is not great, because you'll get all sorts of other things in hospital. What can you as paramedics do? Get them into hospital in as comfortable a condition as they can. And I think one of our big issues over the next while is going to be that whole area of pain management in the pre-hospital sphere. I don't know whether methoxyflurane will go on the formulary or not. It seems to be good stuff. It's been used for donkey's years in Australia, very safely, but it's not cheap. And we have to get it through a whole process. It's probably an awful lot better than Entonox. Is it better than morphine? Not for me, it didn't. Give me morphine, please. But I think that's probably going to be a drug that's going to come into vogue in this country and is going to be very successfully used in the pre-hospital sphere, because the one thing that we can do something about really is pain. The one thing we should do something about is pain. Cervical collars, spine boards, to collar, to not to collar.
That's not an answer.
I know it's not an answer. But you know, if you look at, for instance, neurological deficit after spinal injury, 90% plus of the neurological deficit occurs at impact or within the next few minutes from bleeding. A significant proportion of the rest of it occurs from hematoma formation and from edema around the injury. It is rare that somebody piths a patient like we used to do at Frogs in the laboratory. You just by mishandling them, but it can happen. So my personal view on collaring nowadays is, if the patient is conscious, they will generally have such a degree of muscle spasm around a cervical injury in particular, that unless you really get them by the head and swing them, you're unlikely to move it very much, as long as you are gentle in your moving. And anybody that I've seen handling a patient out of a vehicle in particular, they're very gentle. They're very careful with it. Do you need to put in a KED? Probably not in this day and age. Is it the rule? Yeah. Am I going to change that? Not in the next 6 months, but it may happen over the next little while, because there's a lot of research been done. There's also a lot of research been done to show that one of the biggest problems with trauma and spinal trauma is that if you put a person onto a longboard and you tie them down onto a longboard, if they're a fit, healthy person with no injury at all, within 20 minutes they'll have back pain. And then where do you go? Well, if they come in with back pain and they've got a bit of muscle spasm and they're sore, they're tender to touch, that commits them to the whole gamut of the X-ray and maybe the CT, because you can't read the X-ray terribly well, particularly in the older people who have a lot of degenerative change on their X-rays anyway. So if you can avoid it, if there's an excuse to avoid it, and a lot of the urban stuff there is, the rural stuff, the high-speed stuff, I think you probably can't get away with it at the moment. I'm not going to talk about kids. I know nothing about kids. I used to know a lot about kids, but I felt like my left leg was cut off when I came to James's and we didn't see kids. It was very disappointing, but we still see kids in James's from time to time, and that really does get the shit amongst pigeons. But it's all right. It's basic principles, isn't it, son? And everybody should remember basic principles. What more can I say? My big problem, I suppose, for the past 15 years has been ambulance personnel coming in to emergency departments and being ignored and standing there like, you know, lamps, waiting for somebody to... No, it doesn't happen in my department, or it shouldn't happen in my department. But I think it's unacceptable. I think the place for pre-hospital care personnel is in the pre-hospital sphere. I think once you've packaged and delivered your patient, it is the role and responsibility of the emergency department to accept responsibility for that patient, to take them off your hands, to communicate in both directions in regard to the patient management as reasonably rapidly as possible, and then to pat you on the shoulder and say, off you go. Would you for Christ's sake press the button that says that you are now available? Because otherwise we get bad press and we have Pat Brennan on the phone before I know what's happening. Not anymore. No. Yeah. Small mercies. He's a lovely man. Yeah.
So this is recorded live.
Yeah. That's all right. I am well insured. Although I'm not sure it covers libel, but still.
You've seen it all.
You didn't.
Haven't you? I mean, realistically, how long were you...
The only thing I haven't seen is a resuscitative hysterotomy or a perimortem caesarean section. It is, I think, the only thing I haven't seen yet.
Okay.
I've opened chests, I've opened bellies, I've refused to open a skull, and I was right. It turned out they'd have bled to death if I'd opened them. I've done most everything else. Some of them for the very first time, just seen it in the books and done it for the very first time because I had to. But you know, it's all back to basic principles. A, B, C. When I was starting on the trail of giving talks and teaching ATLS and all of that sort of thing, I used to put up a picture, and I came across it the other day on my computer. I've got this little picture of the Peter Rabbit book of ABC. And there it is, ABC. And I had my 3 kids holding this book and saying, you can teach kids ABC, you should be able to teach adults ABC. And in most cases I was able.
There's famous stories you hear from different doctors of the same era of yourself, which were about the perception of how certain patients were treated and the perception about how certain incidents were happening that somebody who wasn't directly involved in those incidents weren't fully aware. And I suppose one of them, for me, I heard before, was the air crash in the UK. And there was the last one that happened, a big show, the air show that happened. And there was a young guy going on, and he tweeted that he gave out about the air show being cancelled because of the crash. And he gave out because he said his father had paid for the tickets. And this went in all the labels, the red labels, the Sun, the Star, and this was disgraceful. It was a big controversy over it.
Which was the disgraceful bit?
About the child standing up and saying, "I can't believe you've cancelled the air show. Do you know how much money these tickets cost me?" What people weren't aware of was the child actually had autism and went on social media and tweeted about it. And that's not the first time stories of that I've heard about. It's different instances that people weren't directly involved. So it's sometimes when we're having a bad day, when people say certain things, because we can react the wrong way to them on a one-to-one with a patient. So from your experience, can you share any pearls with us about situations where we can learn from?
No.
I'm running out of questions.
Because you've actually effectively dealt with it in your preamble. You take everybody as you see them and as you meet them, and everybody has a backstory. You know, they may be drunk tonight. I have to admit, been there, done that. You know, lost a T-shirt. But people can have a bad day. People can be behaviourally very strange. And you simply have to accept that and hope that it doesn't get to the situation where somebody is so disturbed that they take a swing at you, because then you have to take a decision as to how to deal with that, and that can be very awkward. And I certainly have been in those circumstances. I haven't been, I was hit about 2 years ago for the first time in 20 years because I really didn't see it coming. He was a really mean, nasty piece of goods. But before that, I suppose the previous time, I was, it's all right, you needn't cut that bit out.
I'm driving the Twitter machine here while you're talking.
But the guards cocked up the prosecution, but look, these things happen. But the time before that, I'd have to admit, somebody hit me in the chest, and before I knew what was happening, he was clutching his shin. Because these things can happen almost automatically. But you try to avoid that sort of confrontation. And people who are having a row with you or mouthing off, I think the big thing is to try and de-escalate and to try and disengage, to avoid the natural response, which is to tell them to take themselves and remove themselves from the scene, because they may actually be quite sick. They might be septic, they might be hypoglycemic, God knows what else. And I think that is one of the most difficult bits for ambulance personnel in the field. There are only two of you, or maybe only one of you at the time. It's very much one-on-one. You may even be in their territory as opposed to your territory, and that's an extremely difficult situation to be in. But that's what you learn as time goes on. And you can learn equally the wrong way to do it, usually from somebody else who takes a very negative approach and tells them to piss off themselves or whatever. And that's something that I think used to be more prevalent, is much less prevalent nowadays. It's very, very rare to see that nowadays.
Okay. One of the things that's fascinated me about you in the last, say, 12 to 14 months, because you've retired and you had such a big history in St. James's Hospital, the radios and the media is paying a bit of attention to you now, finally.
Not at all.
You've always been fairly outspoken in your views about emergency departments and how they've been run and different things, and with your dicky bow. And we're sad to see you haven't.
It's not a dicky bow. It's a tie.
You had to say it. You had to say it.
It's a tie. A dicky bow is something that a kid wears.
An adult wears a tie that's wrapped up in a nice bow.
It's a bow tie, exactly. There's a long tie and there's a bow tie. And I don't know if anyone saw the picture of Boris Johnson today. Was it Boris? Yeah, it was Boris. And the tie is hanging down around here. I think, my God, it's bad enough dipping in pus and blood, but, you know, if you miss, you know.
So, one of the things that's fascinating me about that is you seem to have embraced social media, i.e. Twitter, Periscope, PhoneMed. You know, we see you tweeting all the time. What do
I
you
don't
think?
tweet all the time.
I see you
I
tweet.
only tweet now and again.
What do you think of PhoneMed as an actual community, as a system?
I think it's an excellent way of getting information across, and of people accessing information, accessing the views of very experienced people. You still have to be careful. You have to take it with a pinch of salt, because unless you can see where it's been referenced, then there is a little concern about some of the stuff. You've got to be careful about that. You don't take everything on face value. Some people have a bee in their bonnet, you know, about ketamine in particular. Min has a big thing about ketamine. I think ketamine's a great drug, but it's not the be-all and the end-all. So you've got to be wary. You're wary about the information you get. You know, if you get an email in telling you that you've got 10 million in the bank, you just have to send your details. What do you do with it? You know,
You retweet it and tell everybody else.
So I think PhoneMed is very, very good. I think above all else, it's cheap, which means that people will actually engage with it. You buy a medical textbook nowadays, sweet Lord, you have to get a mortgage for it, you know. Buy it online, the bloody thing goes out of date and you can't gain access to it after a few years. It's rubbish.
So all these books are becoming free, and the sharing of information, the sharing of systems that's working. As they said, what we read in a paper is now 2 years old. What we read in a book is approximately 5 years old. But what you see on PhoneMed is current. But you shouldn't let your treatment be dictated by the number of likes
That's correct.
a particular piece gets. So I suppose it's one lesson we can take away. One of the questions that's come in from the Coast Guard in Holt has been, what's the most repeated mistake you've seen coming in from pre-hospital? Not mistake, I suppose it's a wrong, but
That was the word they put in it, wasn't it?
Sorry, Robin. So what's been like the most repeated incident or thing where you would have loved to see
The ETA.
the ETA? Okay.
You know, 3 minutes, 4 minutes, give me a break. You know? And a helicopter. Oh.
You'll never see a helicopter in James.
We do, we see them going over into the RHK. And I can tell you, it's going to be 20 minutes before the patient gets to me.
And what's the ETA you've been given? 5?
Look, I'm told what the landing ETA is, but I know I can add 20 minutes onto that. At the moment, but when the paediatric hospital is built, and it's in daylight, and it's not coming from the coast or the inland waterways or the mountains, then we'll be grand, won't we?
You've had a number of drownings over the year brought into you. I remember coming into you one night with a drowning and saying, is he not too cold? Can we not get this fella? No. He's dead. Thank you. That's all I can say.
Yeah, because the drownings that survive because they are very cold, you're talking about them going through ice, seawater frozen ice, or a foot thick frozen ice in North America, where the ambient temperature is maybe minus 20 centigrade. And they just get suddenly, as if they've been put onto a heart-lung bypass machine and frozen. It's like almost like cryogenics. They have a prospect for survival intact. But if you drown in Irish waters, I mean, how cold does the Irish Sea get in winter? Anyone know? About 4 to 5 degrees centigrade. It doesn't get any colder than that. Do you know, it's like putting somebody into your fridge at home. Be colder in there, be 4 or 3. So that was why I took that view. And took that view a very long time ago. But there is a big difference between somebody who's got a rhythm and somebody who is in a systole. A big difference. So I'll try with somebody who's got a rhythm. Even a pulseless electrical activity. If you go back and look at the research work done in Manchester back in the mid-80s, which was just about when I was there doing intensive care, they showed that people with pulseless electrical activity still had a measurable cardiac output if you put in a Swan-Ganz catheter, and they got a pretty good survival rate from them. But they had short pre-hospital times, and that's one of our big problems here. Urban pre-hospital times are relatively long because of traffic. Rural pre-hospital times, you'd need a calendar. But that's the problem. If you're going to live in a place that's got great views, you know, I was up on one of the 12 bends in Connemara the other day. Fabulous views. There wasn't a cloud in the sky. Great. And I thought, if I go in a bog hole here, how long is it going to take? You know, okay, I had great signal on the phone. That's a help. But then there's going to be actually a vehicle sent. Are they going to send a helicopter first off? Probably not. You know, so it's going to take ages. But the views were great.
The Swords Community First Responder Group, who were tweeting in a question, they say maternal cardiac arrest in an adult hospital. What is the most appropriate management? ALS, what if no ROSC in 5 minutes?
What?
That's the question that was asked.
Maternal?
Maternal cardiac arrest in an adult hospital.
In an adult hospital?
What is the most appropriate?
There are so many bits in there. First of all, what's the cause of the maternal cardiac arrest? Secondly, at what stage do you get it? Thirdly, at what stage is the pregnancy? You know, there's so many bits and pieces. From the point of view of pre-hospital care, all you can do is basic life support and transfer. Okay. That is one of my issues, actually, I'd have to say, and it was an issue that happened in the UK when advanced skills came in first, advanced paramedics, and it has happened here as well. The stay and play has become a problem, in my view. Certainly in the urban sphere. Again, there's a huge divide between rural, where you're going to be half an hour to 2 hours to get to the definitive centre. If you're going to be that long, you might as well stay and play, because you're going to lose it on the way. But in an urban setting where actually you've got 10 minutes to get to the definitive place, if you're going to spend 20 minutes doing loads of pieces, well, you're definitely either going to have a very live patient or a very dead patient by the time you get in. And the probability is it's going to be a very dead patient. Now, they might be just as dead if you come in straight away. But I have an issue with that. And with the maternal one, as I said to you earlier, the one thing I have never done or seen is a resuscitative hysterotomy. Because the problem is at a particular stage in pregnancy where it becomes an issue, where the child can survive and where taking the child out of the uterus may actually help the mother to survive, then you've got very little time and you do not have 4 minutes. As soon as you define that they are in cardiac arrest, you need to cut. And I would suggest that the pre-hospital sphere people should not be cutting. All right, just let there be any doubt in anybody's mind. Do not pick up the piece of glass.
Spoil sport.
Another question that's come in. Michael O'Connor, who's a naval paramedic, and he's watching down in Clonmel tonight.
He's laughing at him.
As you said, KED may be outdated, but any views on the use of the KED for immobilisation of the lower limb injuries? So stabilising pelvic injuries, more so, not from a hemorrhagic.
Has he not got pelvic binders?
But not from a hemorrhagic perspective, from a pelvic fracture as such, that's mechanically and no hemorrhage being questioned, just that we have a pelvic fracture, stabilise the lower limbs.
Well, why not? Jesus, I was taught as an 11-year-old in St. John Ambulance that you could use triangular bandages to do that. Do you know?
Gucci.
But yeah, you can use it if you want to, if it fits. I don't mind. Doesn't worry me.
Okay. I'm just passing these on for you.
Don't try and get out of it, you.
I'm not. Any views on the administration of salbutamol via a BVM in a post-drowning cardiac arrest?
Yeah.
Guess who sent that one in?
But you did say that we are being recorded.
Yes.
So I'm not allowed to say certain things.
Okay. Okay. I'm going to leave you with this one. Hold on a second now and see if any more. Okay. Your greatest achievement to date?
Survival.
Can you expand on that at all?
Look, I'm here standing in front of you. I'm 61 years of age. I've beat the odds, you know. If you actually look at the guys who were born in the neighbourhood where I was born,
Yes.
and look around at those streets, there's a heck of a lot of them haven't made 60. There are a few who have.
Mm-hmm.
We were lucky.
You came from where are you from exactly? From the not the Liberties, the no. Are you from Ballyfermot?
Yes, I'm from Ballyfermot.
He didn't get into the joyriding with the rest.
Now that was my most interesting case, I think, was when, you know, I used to have this old joke that major trauma was when the patient arrived in more than one ambulance. It used to be a joke, but it happened once. No joke at all. A taxi was hijacked on Mount Brown and driven out towards Ballyfermot, and at fierce clip, being chased, and it hit the roundabout, and it was a nice hot summer's evening, and as far as I'm aware, and I wasn't there so I can't be saying, but somebody who, certainly my understanding, was probably driving the vehicle at the time, was thrown across the vehicle as it fell over. It was one of these great big 7-seater vans, and his arm went out the open window as the van came down. So he got scooped and brought in, and the arm came separately. That is major trauma.
You saved the arm?
No. No. But he got a very nice stump. He was very grateful afterwards. Very grateful.
There's a question I've had for a while actually was, we've learned so much in the last couple of years, a lot of evidence coming out of war, battles, Kuwait, Iraq.
It's been coming out of battles for the past 150 years.
Have we learned much from the troubles in the north? What learning lessons have we learned medically wise, trauma wise, from all the trouble that happened in the north? Did we take anything from it?
Well, the guys who were doing the kneecappings learned that if you don't want to kill the guy, and they didn't, they wanted to punish him, you shoot from side to side, not from front to back. Okay? And they learned that fairly quickly. And the message was sent back to them, in fact, by the docs, who said, don't be shooting them in the AP plane because you'll take out the neurovascular bundle. If you shoot them transversely, you get the aim that you're seeking.
And it's a famous Irish doctor that's fairly well known for procedures after kneecapping, I believe. It took those procedures out to some other battles, impossible? No?
Don't know.
Okay. Yeah, I think that's the story there.
Other than that, no, because, I mean, the stuff in Northern Ireland was, they were either shot dead, or there were fairly standard gunshot wounds, or it's multiple blast injuries, and, I mean, that's fairly standard. It was in the Blitz, it was in all campaigns where there have been explosive devices, you get the same injuries.
Okay. Are you going to stay with us? In other words, will you stay on FEC?
I have been reappointed to the FEC Council for 4 years.
Then can you tell us what's going on, because nobody else has any
What do you mean?
So you're going to stay with FEC?
For the moment.
For the moment. Good. Delighted to hear it. Ladies and gentlemen, how do you feel? on a mute there. See, Stan Kyo, would you like to join us? Kyo? Plug in. While we're setting up, has anyone any questions for the prof while he's here in the audience? No? Yes?
I know you had a big history with the ambulance. What do you think the biggest positive changes maybe over the last 30 years in the hospital care for us?
So just so everyone else can hear that, the question is, you've had a lot of involvement with the ambulance service over the years. What's the big changes you've seen over the last couple of years? Yeah. Big positive changes you've seen.
Best uniform in the world.
Don't be such a dick. I think it's been, in fact, the move from the old style ambulance person to the paramedic and advanced paramedic. There's no question about that. And the EMT. I have a concern, and I'm freely express it in this grouping, because I will express it on FEC Council as well. I think we're probably making it too hard for people, particularly for volunteers, to achieve certain standards and to maintain them. And yet, particularly in the places with the nice views, it's the volunteers who are likely to be the most useful in the long term. We can't afford to put 2 advanced paramedics at every crossroads along with the dancing maidens. And even if we did, they won't maintain their skill set. So we've got to actually look at it in a much better tiered fashion. And I think we need to dumb down a little bit, in one sense. But at the upper end, I think we're doing pretty well. I think that's been the big change. And people now don't simply learn a series of things, they learn to understand what they're doing and why they're doing it. And that's what education's all about.
So regards to, say, community care paramedics, critical care paramedics coming, do you see, is that possible in the future, that
I think
take more of a role in the community care of a patient alongside our nursing colleagues?
I think critical care paramedics, unlikely in a sense. Our population's only 4 million. Okay, it's forecast to be, well, it's 4.67 million now. It's forecast to be
That's until Brexit, then it'll all come.
a 6.5 million in the Republic by 2060. But we're still not going to have a huge load of people. And the whole issue about that is, in fact, skill retention and refreshing. And you'll have very few people doing that.
Okay. Happy enough? Okay. Thank you very much. Anybody else? Yes, at the back.
Yeah, I just wanted to know, I've been looking into CPR and the English and the Irish versions are slightly different with hand placements, and I'm just wondering, is there much of a reason why that is? Centre of the chest for the English version, whether it's in between the nipples for the Irish version?
I'm not quite sure what the difference is, centre of the chest. And I'm not trying to be awkward about this, but actually, as long as you're more or less central, you're doing CPR reasonably. I actually don't think CPR makes any difference. That's a personal view. The only thing that works is defibrillation, in my view. And the earlier you get defibrillation in, the better. In fact, if you don't get it in fast, it's not going to work. If you get it in very fast, you have people sitting up in the ambulance on the way to hospital talking to you. And I'm sure lots of you have either seen or heard of cases like that. One of my classmates from medical school was one of those cases where volunteers on a Christmas day were at a run and he collapsed in VF and he was defibrillated and he came round. And that, as far as I'm concerned, CPR is only a temporising measure until such time as you can get an AED to the patient. And if you can't get it there very, very quick, well, sure, you might as well call Massey's.
As I said, live and recorded on Twitter. Were you sacked or did you leave? That's
That is a personal, professional view. It is not the view of FEC Council. This is a party political broadcast on behalf of Pat Plunkett.
Okay, anybody else? No? Okay, can I ask you to put your hands together? I can't believe we had a Professor Pat Plunkett. Do you want to stick this on your side? I'm going to use it for a second so I can speak to the people around the world. Yeah, just stick it on that one there. So next up, for those of you who don't know, is Dr. Stan Keogh, who's a consultant paediatrician in Tala Hospital. He's joined by Rachel MacDonald, who's the CNM3 from Temple Street Hospital. And Ike, I don't think, are you here in support? I am in support. Dr. Ike from Temple Street, who's here also in support. He's actually being Claire. Claire's at home watching because the kids won't let her out. So Ike, we're really very proud to have Stan with us to give us his pearls of wisdom when it comes to the younger patients, the little people that we deal with. Stan has had a great interest in pre-hospital care and wants to get more involved and wants to work more with the likes of us guys here to bring what's working inside the hospital outside of the hospital. He feels there's a couple of things we could be doing a little bit better. I'm not saying we're doing wrong, but we just could do them a little bit better, and he wants to share his pearls of wisdom. So Stan has agreed to do, and between Ike, Claire, Rachel and Stan, they've agreed to do 3 nights as regards to paediatric master classes. So we'll do this one, we'll probably do one in February, and then we'll do one in April then as well. Okay, so can I ask you to welcome Dr. Stan Keogh.
Thanks, Pat, for those pearls of wisdom. Hopefully, built to follow this anyway. And as Glenn was saying, what I'd like to do is to sort of give you a flavour of paediatrics. I might know some of you from giving lectures with the APs, and there's always a lot of conflicting stuff in the CPGs that are currently available in the AP manual and what we sometimes do. So I suppose this is just one way for me to sort of clarify some things, and maybe in many other ways for you guys to get involved and ask me questions in the forum, this kind of forum, which I think is very, very important. Okay, masterclass I think is too posh for us. We're not that way really. But today, because Claire did something about respiratory stuff, I'm going to move on to the circulatory aspects today and maybe concentrate mainly on that. Our next masterclass, I'll do something on disability and trauma, and then we'll end with a revision on respiratory again, if that's okay. So that's kind of really what we'll be doing for the next 6 months or so. Okay. I have Rachel here, and like I said, Rachel, not only is she a resource training officer, but she also has done a lot of work on early warning scores, and in particular to identify deteriorating children in the wards. I think that's a really, really important thing, because when you go out in an ambulance, for example, I know a lot of the trips are short, but you start some treatment, how do you know, for example, that it's working? Yeah, I mean, you've got to gauge it against something, and that's where Rachel has been doing a lot of work. Okay, so I'd like to sort of invite her later on to give you a structure and maybe some thoughts about, can we incorporate this stuff to pre-hospital care, because I think that's really, really important. Okay. The other thing as well that I think we do sometimes quite badly, and Rachel has done quite a lot of work on, is how we listen to parents. So it's not like the patients that Pat, for example, will have. They're adult. They can tell you exactly what's going on. They're verbal. But children aren't verbal sometimes. So you go into a house, for example, you rely on the parents, for example, to give you that history. How do we listen to them? And the way we listen to them is really, really important, because you take certain cues from them, and sometimes the cues may be okay, may give you sort of indications of how the child is. Sometimes we totally misread them. So I think it's very important to listen to the parents, and Rachel has done quite a bit of work. I'm going to ask her to talk a little bit about that. Okay? So the structure will be just to take you through an overview on pediatric emergency and resuscitation, and concentrate on circulation. Cool? No? Cool. Okay, excellent. This is a slide that if any of the APs, I suppose, I put this slide up, and it is really sort of important, because 99.9% of children, and practically all children that come into our EDs are not in the red slide. this red slide down here, cardiac arrest. If they are, and I've done this for over 20 years now, you know, the rate of which we successfully resuscitate a child in cardiac arrest is really, really low. So you really don't want to go there. It's sort of somewhere that, you know, you want to prevent. So how do we prevent it? Well, we prevent it, as we all know, by recognizing the issues. So early recognition and then treating the issues. So we go back 2 steps to, and we're talking about circulatory failure here, we go 2 steps back, okay, to the causes of it. And if we know what the causes are, when we arrive at the house, we ask the appropriate questions, we identify the problem, and we start treatment. It's as simple as that. Well, technically, okay, but it is. So for example, if you have a child with vomiting and diarrhea, I mean, every child, I think, in Ireland has vomiting and diarrhea at the moment. It's crazy. So they have vomiting and diarrhea, or some combo of that anyway. Okay, well, they have fluid loss, right? So identify the problem, start some treatment, whatever it is, and we'll go through the steps of that, okay? And hopefully prevent getting down to circulatory failure and preventing cardiac arrest. It's as simple as that. Okay, likewise, Claire would have gone through respiratory failure and the problems there. So I'm not going to dwell on this slide. Suffice to say that if you treat the initial problems at the very, very top, you should be able to get out of jail quite successfully. Okay. And look, I'm open for people to take these slides. I mean, it's not a, you know, will these slides be, Glenn, these slides will be available to people, I suppose, given the things? All that, yeah? Yep. You know, so that's fine. And how do we do that? So how do we recognize that? And this is a really respected algorithm. I mean, we know about this. Everyone knows about this. You know, I'm just putting it up just to remind and refresh ourselves, I suppose, as to what the steps are. You know, it's not that we're simple people, that we follow A, B, C, D, E in that order, but it's a really simple way, you know. So our primary assessment is airway, breathing, circulation, disability and exposure. Okay, if we do it in that order and we assess patients in that order, then it's systematic, we'll identify the problems early and we'll be able to sort them out. Simple. Okay, and then obviously we'll talk about resuscitation and secondary assessments later on. But again, this is where I wanted to concentrate on today. But I will have to touch on airway and breathing, obviously, to get down to circulation. Okay, so before we start, we have to recognize the problems. Before you get to primary assessment, you guys will go in or go into a house. You call 999. You go into a house. As I said before, you will encounter a parent or guardian, their babysitter or whoever it is. Johnny is sick. Well, why is Johnny sick? Okay, Johnny's sick because of X, Y, Z. Okay, and this is where I said we have to sort of listen carefully, take these cues up so that we have a good history and we can elicit the problem. Okay, so I'm going to just pass you over to Rachel now. Some work she's done about asking these questions and eliciting the right things. I'm going to put this. Hold it.
I'll hold it.
Hold it, okay.
Rachel, you told me you were going to wear a Christmas jumper.
I lied. For the benefit of everybody at home as well as in here, I have got photographic evidence of Santa from Saturday afternoon for 3 hours at my kids' Christmas fair. So I wore my Christmas jumper on Saturday along with Glenn's Santa suit. So yes, my name is Rachel MacDonald. I am a CNM3, but I'm a CNM3 with the HSE at the moment. I'm the National Pews Coordinator. I spend time in Temple Street, but my background is Crumlin, just in case there's any conflict of interest going on anywhere. I'm working on the pews, right? This is the national strategy for early warning systems. There's an adult one in place, there's a maternity one in place, and I've had the lucky job of working with the paediatric one over the last 2 years. So what we've done is we have developed 5 age-specific standard observation charts for use in every admitted child in the country. We have a training package that goes along with that, and we've got an auditing and monitoring tool, and it's all supported by a national clinical guideline. It's for in-hospital use at the moment. It hasn't been validated for use outside of hospital. It hasn't been validated for use as a triage tool in ICUs or in theatre. But it's really, really useful to standardise everything else that we do, the communication that we are talking about patients, and it's working really well, ED to ward, ward to ward, hospital to hospital. So it's helping everybody. Now, we have a number of scoring parameters, and one of those parameters is concern. It's concern on the part of the parent or carer, but it's also concern on the part of the clinician, and that clinician could be one of the nurses, it could be one of the doctors who's assessing. But what we're really, really concerned with getting to the bottom of is what the parents think. We know that if a parent says a child is incredibly sick and they're desperately worried, we usually know that that means something, most of the time. But we now are trying to translate it into a number on a page. It's just a 1. It's a simple scoring system. But if it's significant clinical concern, that gives us a real push, a real drive to maybe push a bigger, redder button than it would otherwise. So we launched, and we talked to people, and we went around the country. There are 32 hospitals that have implemented PEWS to date, and that doesn't include the 11 private hospitals and a number of other centres that have started using it, including, actually, I just heard yesterday, there's a mental health setting that have just adopted it, and there's also some pre-hospital home care teams that have started using PEWS. So as I said, it's not been validated for that, but it is publicly available on the internet. So it's been pulled off and used to monitor and communicate a deteriorating child. So when it came to the parental concern, we found that nurses were scoring a 0 because they felt that the parent wasn't concerned, or they were scoring a 1 because sure, all parents are concerned, otherwise they wouldn't be here. So the score wasn't valid. So then we thought we have to do a little bit more work. And as part of that work, I went and did a quality improvement diploma, and this is sort of almost the end product. I don't believe in starting from scratch and doing all the hard work myself, so we went looking. And as luck would have it, Birmingham Children's Hospital had already done all of this. They had posters, leaflets, lots of communication devices to talk to parents and help them to say what they felt was wrong. It's not always easy to know what you feel is wrong, so we've just experimented a little bit with giving parents the language that they can talk to us and put their finger on it a little bit, but all the time remembering that if they say, they listen to that and act on it. So what we did was we took the tools and we talked to a group of parents, we talked to a group of medical students, pre-hospital carers and nurses and a couple of medics. And we scrapped a lot of the Birmingham materials and we decided to keep it absolutely dead simple. We came up with one leaflet. Most of it is contained in this one page here, and we sold it to 2 wards in Crumlin and 2 wards in Limerick Children's Hospitals. And what we managed to find out was that the leaflets were great and everybody liked them, but nobody remembered to give them out. And when they were given out, nobody remembered to read them or where they put them. Or mum read them, but then she went home and dad came in, or granny came in, or the auntie came in. So we failed at the first hurdle. So we rethought the whole thing and we made posters. They were too small to be read. Somebody stuck another poster over them. So we went back to the drawing board again. We made the posters bigger for them. And we stuck them up on the walls. And within a week, every parent on all the wards had seen the posters. Every parent on the ward reported feeling valued, listened to, more confident. And we had a couple of parents who came to us and cried. Because if somebody had listened to them on a previous occasion or with a previous child or earlier, then this wouldn't have happened, that wouldn't have happened. And perhaps they would have had a better hospital experience previously. So we learned a huge amount from that. Essentially, keep it simple. Always listen to the parents. One of the key things that we found by accident was that nurses weren't necessarily asking the parents what they thought about the concern piece. What was happening was that we were all dealing with the parents and we were sort of thinking to ourselves, they're just anxious, or they're very concerned. I'll ask a few more questions. So what else happened is that we started making sure that 100% of parents were asked 100% of the time what they thought of their child. And that made a big, big difference to our parent cohort as well. So what we've now managed to come up with is one poster for parents and one poster for clinicians, but they're all A3 at least, if not A0. They're on the wards that everybody can share and learn from. And there's a leaflet if anybody wants anything extra. We've also put that on the hse.ie website, and that's absolutely available to download for anybody. And they're really, really good, really simple resources that can actually carry over to OPD, to out of hospital, to any parent interaction, just to make them feel that little bit listened to and to remind us that we don't know everything. We think we do a lot of the time, but actually it helps to ask. It's fantastic to be asked. You do feel listened to, you feel valued, and it helps the entire patient experience, and it means that we learn a little bit more from them. So that's my piece, that's listening to you.
Thank you, Rachel. So listening, as Rachel said, is really important. This is available in a modified format. This is one that we produce for one of the hospitals in Tanzania that we go up to as a group. So this is available and constitutes part of this Pews thing, which Rachel will present the second part later on. Remember, listening and obtaining the right information is really, really important when you go and assess a child. Okay? So, this is really, really basic stuff I'm going through. Okay, this is really basic recognition stuff, because if you miss any of these steps, what happens is that you invariably will go down that route towards circulatory or respiratory failure, and the consequences are that you increase your mortality. Okay? Okay, so I'm going to talk 1 minute about respiratory failure, and then we're going to go on then towards circulation. All I'm going to say about respiratory failure, and people know this from my lectures, is that you assess respiratory failure with the 3 key components: effort, efficacy, and effect. Okay? We look at respiratory rate, we look at accessory muscle use, we look at flaring of the nasal bones, the nasal ala, and we look at the child's position. Okay, we look at chest expansion, we listen to air entry, and we have pulse oximetry to aid us too. And we know that oxygen saturation of less than 85% in room air is bad. It's a pre-terminal sign. It's somewhere where we don't want to go to. Okay? And that's all I'm going to say about that. Moving on to the nitty-gritty, I suppose. Circulation. That's why you're all here tonight. Okay? The recognition of shock. Okay, and I'm going to go through some of the cardiovascular signs. I'm going to play a couple of short clips that these are all available on YouTube. I just want to demonstrate and highlight what they are. And again, it's just to remind us all, we all know this already. And then I'm going to go through some treatment modalities for circulation and what we can try and do to help these children who are in circulatory shock. Okay, so can I just play this for a second? Okay, this is a tube from YouTube again. Glenn, this is
Yep, that's sound.
the sound, is it? And which one is it now?
On the back.
I have 2 of them. I can't see. Yep.
You can go to C for circulation. Check peripheral and radial pulses for rate, regularity and strength. Check extremities. If they're cold, capillary flow time is best done on the central sternal approach. Press for 5 seconds. Return should be less than 2 seconds. Recheck the patient's blood pressure for any abnormality. Electronic sphygmomanometers are good, but manual may be more accurate. If there's any problems with the heart rate, such as a tachycardia, please apply 3-lead cardiac monitoring and a 12-lead ECG. You don't know if it's a tachycardia or a tachyarrhythmia unless you look. Look at the rate and rhythm. Assess if it is a tachyarrhythmia. Please gain IV access as quickly as possible. Whiteboard cannulas in antecubital fossa, preferably 2. And remember, blood comes out, so check for some blood analysis. Use these FBCs and lab glucose. If there's a problem, treat. If not, you can then go into D for disability. Check the patient's health poo. Remember, A, B, C, D, E, F, G. Don't ever forget the glucose. Centrally would be fine, but peripherally, if you need a quick result.
Okay, so the 4 signs that I always harp on about when you're assessing circulation: the heart rate, pulse volume, cap refill time, and blood pressure. And I always used to ask even the medical students, paramedics, advanced paramedics, I mean, like, if you had one of those 4 parameters, which one would you choose? And you get, everyone choosing their own one, really. It's a trick question, isn't it, I suppose, because we can check all of them. And we have the tools to check all of them. Whether we check it manually or whether we check it automatically now, we should know how to do both. And we should check all of them. Okay? So, this is the crazy thing. So in adults, the pulse rate is more or less fixed. Right? The blood pressure is more or less fixed. Your weight is more or less fixed. The age goes up and down, obviously, or whatever. Right? But in children, they're not. I've been meaning to give everyone one of these cards that we have. So this is one of the cards that I set up in Sydney at first, and then we brought it back to Tala, we introduced it to Temple Street, Crumlin have their own too, and everyone has a variant of it now, and so should you guys, I suppose, whereby instead of having formulas and stuff like that, you have a pediatric emergency resource guideline. So at any age in particular, you go there, you'll be able to get a median or an average, I suppose, weight, and therefore an average blood pressure, systolic rate, heart rate, respiratory rate, and a few drugs that you might be using. Okay. So again, you have gone to the child, you've assessed the child, you've asked the mother some questions, you have diagnosed a problem. So if it was vomiting and diarrhea, you've diagnosed gastro. You do your observations. What happens next? Child goes in an ambulance. There is, let's say, a half an hour delay before going to hospital because you're that far away. Okay? How do you know whether a child is deteriorating or not? Child could be deteriorating. You might start some treatment. You may not start any treatment, but how do you know a child is deteriorating? Well, we do repeated observations, don't we? Okay? But is there a simpler way of doing it? So in the wards, we're going to start introducing an emergency soon. Okay, we have these pew charts, which is where Rachel's going to come back again. These pew charts can be single trigger or multiple trigger, as is the case here. But what will happen, essentially, is that they will breach certain parameters that have been pre-decided by us. And if they breach certain parameters, then we act differently. There is a response to that breach. Okay, so again, I'm going to get Rachel to come down and have a chat to you about the vital signs and breaching parameters on them.
Wasn't much of a break, was it? Okay, so this is my day job, this bit. We haven't got the Irish Pews chart on the slides, but I do have a physical copy that I stole shamelessly from Temple Street earlier today, so you can have a look at that. So the idea is that we've got these 5 different standardised parameters for the age groups. We've got 0 to 3 months, 4 to 11 months, 1 to 5 years, 5 to 11 years, and 12 plus years. And that kind of meets then the adult criteria, which usually starts anywhere between 14, 15, 16, 17, 18, 19, or 20, depending on what hospital you present to. This particular chart is one that we designed specifically for a paediatric oncology department that we support in Tanzania. We've kept this one much more simple than the Irish system. This is just based on a single trigger with just 2 levels of response. 0 is okay, or white is okay, orange is a level 1 response, and purple is a level 2 response. And there's no threshold for decision making because this is completely new. They haven't had a system like this before. The Irish system works a little bit differently in that it is a numerical score with integrated scoring, colour coding. It's certainly a little bit more complicated. 6 core parameters, 3 additional parameters, and 2 non-clinical parameters. It's easy when you know how. Essentially what happens is you do your observations, tot up your score, and refer to an escalation guide on the front, which sets out recommendations for care, including frequency of observations, who do you call, and who needs to come. So it's a very, very simple tool, essentially, but it's complicated by the use of clinical judgment in paediatric practice. You can have high scoring children who are actually pretty okay and you're on top of everything, or you can have a very low scoring septic infant, for example, that really the only thing wrong with them is parent concern and a bit grey, bit floppy, bit off colour, but physiologically their vital signs are normal. So a lot of clinical judgment required in the paediatric setting when it comes to an early warning score or system. And that's why the Irish one is a system that it's a lot more than the score. It's how does the child look, how does the parent seem, how do you feel, and what do you think is the best thing to do. And it gives you a structured communication piece, which we use ISBAR in hospital. And I know that you had a session last time on I Missed Ambo for your handover piece. So ISBAR is just what we use for that. So if you have a look at this little chart here, we've got upper and lower orange and purple warnings for each one. Oh, have we got more? A 12 plus years. So we've got the teenagers. So you can kind of see where the colour coding is changing. We borrowed quite shamelessly again from this one. This is based on a really, really nice system from the Royal Victoria Hospital in Melbourne called Victor. Also freely Googleable. And actually on the Victor website there is a whole series of videos on how to assess children of different ages. They go through an ABCDE assessment process on actually very similar ages to our Pew's charts. They're quite useful. victor.org.au. I can see some of you scribbling. I'll give them to Glenn later if you like. So it's a very simple system here, and we've got clinical prompts then for the nurses to help to communicate to the medic what it is that they have found. This might be a system that could be at some point developed for pre-hospital care, and I think the real benefit is one of the biggest issues is that ETA. It's getting the communication right, and certainly one of the things that I used to find on the other end of the phone was things like percentage burns and hearing the age properly and what you say and what we hear, because it isn't necessarily what you say, very much it's what we hear as well and how we hear it. And if you've got a set structure for observing, handing over and listening, communication can actually work an awful lot better for us. So knowing what information that we are looking for, as well as an understanding of what you're going to give us, can really, really help. And I think that's where Pew's may begin to work, and we may be able to have a pre and in-hospital interface. That said, that's not in my contract at the moment, so if FEC wants to do anything for me, I'm free on to January the 1st. I think that's me.
Yeah. Thank you. So that's just throwing it out there for you guys, isn't it? I mean, you know, what we're trying to do here is not rocket science. What we're trying to do, as Rachel was saying, is to standardise treatment. It's just like when I first started, you know, you had a Brownlow tape. Why was that? Because we spoke the same language, isn't that right? You know, so just like here, if, for example, these charts were standardised across the board, then what would happen is that we would all speak the same language. We would know the level of response that would be appropriate for a child or adult. I mean, it doesn't really matter. You know, it's across the board, and the least amount of bits and bobs we have to deal with, and the more standardised we get, the less mistakes we make. And I think that's probably where we fall down sometimes, isn't it? So pews is something to consider. I'd like to maybe start developing that a little bit. So just to go back again, what were the, how do we examine a child for cap refill? I'm just going to play a couple of videos for you.
Capillary refill time is measured by 5 seconds of pressure on the sternum. Here, this is normal at around 2 seconds.
If anyone has questions about these videos, if you wanted to shout now, it would be quite good.
Part of the assessment of the degree of dehydration involves assessment of skin turgor. Gently pinch the skin. The elasticity is reduced from moderate to severe dehydration.
Okay, so what happens then when you have really poor skin turgor? What happens when you have increased cap refill? What happens if the pulse rates were above or in the purple or orange zones? Well, you have circulatory inadequacy. Okay, and what are the effects then? Well, the effects, as I said to you earlier, they're not just confined to the circulatory system. There's knock-on effects. So if you have that, you're going to have a change in respiratory rate too. Your respiratory rate may increase. You may become tachypnic initially, and as you get more and more tired, a child will become bradypnic actually. The skin temperature, we all know what happens. They get cool, they get mottled, and the mental status changes. Children come in, and children don't look at myself or yourself sometimes and go mad, although they do a lot of the time when they're very small. They may do that because they're hypercapnic, so they are not breathing, they are retaining carbon dioxide, they are hypoxic, so they become agitated and they become irritable. So you can see that respiratory inadequacy also has, circulatory inadequacy, has also got knock-on effects with circulation. Okay, what are the common things then, as I said, of circulatory, or the problems that cause circulatory inadequacy? Well, hypovolemia we've said about, so the most common cause now, vomiting and diarrhea. And the second most common cause, I suppose, that will come into us where you're hypovolemic, maybe from trauma. But again, I will talk about trauma in the next sitting. Sepsis is very common too. The younger the child, the higher the risk of sepsis. So I always say to the NCHDs, when they come in, if a child is under 1 with a temperature, that's the first thing you think about, sepsis. Anaphylaxis is common. We've had a few examples in the media over the last year or so, and I'll show perhaps a quick clip of that and the treatment modalities that go through that, and sometimes burns too. Okay, so everybody happy with recognizing circulatory failure? Heart rate, pulse volume, cap refill, perhaps blood pressure. Okay, so if you have a child that is shocked, prolonged cap refill time, they're tachycardic, okay, what do? Quick shout, anyone. So you see them, you've talked to the parents, they have a temperature, for example, the child is irritable, the child has a prolonged cap refill, they're sick. What's the first thing that you would do? Sorry?
Sample history. Start asking more questions.
Yeah, you could, but let's say you're happy that this is a potential sepsis.
Oxygen.
Oxygen, yes? Anything else?
Paracetamol.
Paracetamol. Fluids. Yes, all really, really good. Simple things first, and I think we always forget, and whoever said paracetamol, we forget sort of simple things that we can do first. And I think that it's while you're waiting for the chicken to be cooked, so to speak, right? You can, someone can be all giving something, okay? So analgesia and antipyretics are nearly one the same if the child is very small. You can give paracetamol, you can give ibuprofen, yeah? If analgesia is required, you can add diclofenac, methoxyfluorine, fentanyl, and morphine. So I'm going to talk about that first. Okay. So paracetamol, ibuprofen, and diclofenac. Yes. There's a study that's starting with UK, and Michael Barrett, one of our colleagues in Crumlin, was getting involved with that with methoxyfluorine. We've used that in Australia for many, many years, and in adults, as Pat was alluding to, Glenn was alluding to that too, I think, earlier on, it seems to work very well with adults. With children, I've had a load of children come in with the green tin whistle, as they call it, and it doesn't really do a lot for them. That's anecdotally, I suppose, and there are some randomized control studies in Australia that show that if you take a child and you give them the smiley face, yeah, and the not so smiley face, and then the not so smiley face, and then the not smiley face at all with tears, they end up still around that same level. Whereas even giving something like paracetamol or ibuprofen shifts them up back towards the smiley range. Those are the RCTs, randomized control studies. So for some strange reason, and I don't know what yet, I've looked it up to date in the last year because I knew that methoxy was coming into Ireland, and there's no good randomized control study that proves that it works well in children though. Okay, what works well in children, if you're going to give some pain relief, if they're sore, they're septic, whatever it is, fentanyl is very good. And I know a lot of you guys are using the intranasal route now. Intranasal fentanyl works really, really well. Very good randomized control, well, not very good randomized control studies. I mean, with children, it's always hard to make that possible. But smiley face, again, they go well back up to that smiley face. Okay, so it works very well, intranasal stuff. And of course, morphine is everyone's favorite. Okay, and antipyretics, very important. So I said there was a temperature there. You know, before that child gets a febrile convulsion, let's give them something. Let's give them something. So paracetamol and ibuprofen can be given. Ibuprofen and diclofenac, as you know, are non-steroidal, so don't give them together. And there is this one thing that people will say, that non-steroidals can cause renal failure, can't it? It can cause problems with the kidneys. I think that you have to weigh all this up, and certainly I used to work in the renal with the renal consultants for 6 months in Temple Street. So we used to get all the children with renal failure caused by NSAIDs from everywhere in the country. So actually, I used to give diclofenac like Smarties, and now I sort of think twice a little bit, you know, about giving that. But it is still, look, is the child going to get a febrile convulsion, or are you going to try and help the child? So I think that, you know, you always balance. There's always a risk assessment when you give drugs. Okay, so antipyretics and analgesias together. Think of those first, because they are simple things that can be given to the child so that the child settles as you assess it and start using your other modalities. Okay, the child is sick. Let's go back to that child with vomiting and diarrhea. And the child may have a prolonged cap refill and be tachycardic. So the child needs fluids. You're talking not oral fluids, I would think, at this stage. And again, I'm not going to go into huge depth and detail. We're talking about giving intravenous fluids or intraosseous fluids, is that right? So it doesn't, I mean, we all know that intraosseous fluids, and people have done contrast studies with this, intraosseous fluids go in pretty much just as quickly as intravenous. So don't faff around. You guys have, the paramedics and advanced paramedics have easy IOs now across the board. APs only, okay, have easy IOs across the board. Really, really easy to use. And I'll show you one of these mad videos that was done in America where someone just decides to screw themselves with an easy IO. Not so nice, but it is done. So fluids, very important to give. Okay, and then the perennial question that people ask, and I'll go through this now. If there are questions at the end of it, you know, I'm happy to field that. But that's the whole perennial question. If you ask 3 ED consultants, Hartmann's or normal saline, you'll get 3 different answers. Although there are only 2 IV fluids, right? You'll get all sorts of answers and all sorts of rationales behind it. What we need to give, if a child is shocked, you need to give some fluid. You need to give a reasonable amount of fluid, and a child will have about 70 to 80 mils per kilo of body circulation, and we recommend 20 mils per kilo as a single bolus. So that's reasonably well documented for a medically sick child. And again, whether it's saline or Hartmann's, if you're giving 1 bolus or 2 boluses, it doesn't make an awful lot of difference. We can talk about the differences and the nuances in fluids later. You need to give fluids, they need to be isotonic or reasonably isotonic, and you need to give enough to correct that shock, because shock will kill a child. Yeah? And then this is probably after pre-hospital care and in hospital care. The reason why you're giving all these fluids, the reason why you're giving the analgesia, the reason why you're giving the antipyretics is when you deliver the child, fluids ongoing with all the other measures in place. What happens if we can't correct any of this and we still keep on going down the road, 2nd bolus, 3rd bolus, for example, 4th bolus, then what we need to do is we need to resuscitate using other modalities. And the other modalities, which again I can talk to, but I just want to touch on so that you guys know what comes down the line, will be things like inotropes, for example. And those same inotropes are used, for example, in cardiac arrhythmias, because as we know, we give epinephrine or adrenaline as an infusion if, for example, we can't correct shock. Likewise, if you have asystole, that's the asystolic algorithm that you guys will be using, or the emergency medical team or paramedics, advanced paramedics might be using. And then if you have cardiac arrhythmias, amiodarone could be given too. Again, using the cardiac arrhythmia protocols. Okay, so those are the flavors of treatment modalities that you have to think about. Again, what I was saying to you is, how do you deliver them? Well, hold on, something wrong there. This is how one person delivers them.
Also, the toxins get you on, yeah. So the drivers you're going to keep for a while. Now it varies, because you guys are out in extreme temperatures, where they're out in the rigs or the fireplace, cold weather, that affects the battery cycle. It might be more or less depending on in the hospital lasts longer. You guys are outside in the heat and the cold, in the extreme temperatures, that might shorten better out there. You guys for anything else? Fine lamp, go through the skin first, make sure you still see the hash mark, and make sure you're perpendicular to the bone. You're not going at an angle like an IV, you're going 90 degree angle. That's what we kind of do first thing. Where's Jerry? It's like, you're going to feel the bone. I go through the skin till I hit bone. You hit bone, make sure you're perpendicular, make sure you see the hash mark, and advance. You're in. You feel it drop in? Right.
This guy's awake and having a bit of a laugh, I'd say.
So, you can almost hear the amps change a little bit. When you can hear it sounds different, and it also dropped in there. You feel like you lost resistance. I can hear it like downward toe.
Pretty impressive guy.
There are little branches. That's not supposed to happen, actually.
So the ever wonder why paramedics aren't using this drill, because it's €100 per needle. €100
Is it?
Yeah.
It's €30 now, no? Less than that. You're biting off the wrong company, I'd say.
We're not the only company that can bring it in. They give it to go in for free.
For free, that's right, yeah.
Yeah, because we're spending so much money on needles.
And perpendicular to the bone. Now, one other way is to aspirate slowly, really slowly, and you'll get the venous-looking blood come back into the tube. It might hurt you. You okay? Well, there you go. Does that hurt? I mean, I can feel it. Dull. There we go. Is that blood? We can send that blood off to the hospital for labs. I send the first about, you don't get as much blood out of tibia as you can in the humerus. I can get 10, 20 cc's out of the humerus most of the time. But the first cc... So that's very great to verify you're in the right place.
So take your screwdriver and then now you're going to take it out.
Take your screwdriver, take it out. What about it?
We can have extra container, please.
So the insertion pain was what? 0 to 10. You're already saying this. How about 3? 3, 4. Turn clockwise and push straight back. with some force. Just pull straight back. Keep turning and pull back, straight back. See, it's harder than yours. You know why? It's a weight-bearing bone. The cortex is thicker. Did it hurt pulling it out? Like a full instance here? Less than the insertion pain, usually.
Hold it right there.
Okay, yeah. I just wanted to show you the whole lot. This is one of many. And the interesting thing, I kind of thought about this was, I used to think it would be quite sore. Would you? I mean, like, you know, quite sore. So obviously, as Glenn said, the reason why we don't use it as much is because it's so expensive. Not because, no, so seriously, I mean, we use this in children quite a lot. The two things to highlight about this, you saw the color of that, so that's a blue, which is an adult needle. They are red ones, which are kids ones, they're much shorter. Gauge is the same, 15 gauge throughout, okay, but they are shorter. It doesn't cause a lot of pain. There's a little bit of pain when it pricks the skin, and a little bit of pain when it breaches the cortex, obviously, because there are nerve roots there. Otherwise, there is no pain, to be honest with you. So if there is a lot of pain, you're doing something wrong. Okay? But if you're using it, as I said, in children, remember there are two sizes, so that's all. And it is a really, really, really effective way of delivering fluids. Okay? So don't forget that. Okay. I'm going to move things on just a tiny bit, I suppose. I suppose when you have circulatory collapse and shock, again, one of the things that will be affected would be your D, which is disability. So never forget about that. Always monitor the conscious level. And for us, it's really simple. We've got AVPU. So AVPU sort of, you know, I know people kind of cringe a little bit, you know, but so what? I mean, if you say, or a registrar says to me, you know, the child's responding to voice, that tells me pretty much everything, doesn't it? You know, voice, GCS 11, which means it's not normal, something needs to be done. Because if you go to that Pew's chart again, that just means that you've triggered a problem that needs to be looked at. So AVPU is absolutely fine. Posturing is very important because, again, that's a sign of neurological instability, and pupils, obviously. Okay, and alert, voice, pain, unresponsive. Okay, so essentially, I'm not going to go through airway and breathing. Today was circulation. Okay, today was circulation. We talked about recognizing the four cornerstones, I suppose, which are heart rate, cap refill time, blood pressure, and skin temperature. If any of those are outside the parameter, then you are concerned, or you should have some concerns. How do you treat it? Using antipyretics, a little bit of analgesia. If they are still shocked, cap refill time is prolonged, they're tachycardic, then you probably need to start some fluids. Inotropes or adrenaline if they are, you know, if they are going down that cardiac arrest rhythm, and then deliver to the hospital. Okay?
Stan,
any questions?
Just go into slightly about inotropes. Not many people may realise what an inotrope is, or access to an inotrope at the moment.
Yeah, I mean,
we're not using them at advanced care level. There are some studies that have shown in the States where they're using 1 in 100,000 of an adrenaline, so they're drawing up 1 in 10,000 in 1 mil.
Okay. Okay. I suppose inotropes are drugs that we use in asystole, right? Which support the cardium, and therefore, if you are asystolic, you want to start good CPR, and adrenaline we know will increase heart rate. It also is a vasoconstrictor, so if you are vasodilated from sepsis, for example, if you can't maintain your blood pressure, you can't maintain the circulation, obviously squeezing the blood vessels causes everything to go back up again, your circulation improves, you have better perfusion to the body. So that's essentially what an inotrope is. The most common inotrope that we would use is adrenaline. There's noradrenaline as well. There's dopamine and dobutamine, although we don't use those much. So we concentrate on adrenaline. That is the most common one. The question to what Glenn was asking, for example, was the strength of adrenaline. So essentially, in pediatrics, we use the 1 in 10,000 strength of adrenaline, and the dose is 0.1 mils per kilo of 1 in 10,000. 0.1 mils per kilo of 1 in 10,000. So that equates to, if you are a 10 kilo child, 1 mil of 1 in 10,000. Okay? Is the dose. Or in asystole. In asystole. Okay? What is the dose that we give in anaphylaxis, for example? So it's in the CPG. What the dose of that is? The same. The same. It is the same. It's the same. It's 0.1 mils per kilo of 1 in 10,000 as well, actually. But if you give, so to give you a different scenario, the child is now 10 years old, and a 10-year-old will weigh 35 kilos, for example. Yeah, 35 kilos, more sometimes. 0.1 mils per kilo is 3.5 mils of 1 in 10,000. Is that right? 3.5 mils. So take a syringe. Try injecting that intramuscularly. 3.5 mils. Got like a conker in your arm. And it is really, really sore. So if you're willing to do that, if that's all you have, that's fine. You can give that. So the reason why a lot of people use 1 in 1,000 is to reduce that huge swelling that's there. So instead of 0.1 mils per kilo of 1 in 10,000, you give 1 in 1,000, but it's 0.01 mils per kilo. See, same dose, isn't it? Just using a different concentration, that's all. So yeah, look, I more or less have finished this now. So, so from what you've heard about circulation today, are there any questions?
Any from the audience?
Because I've kind of gone very vague and general with stuff. I'm sure.
So we have a couple coming in on Twitter.
Yeah.
That's all right. Stephen Kemby is literally biting, chomping at the bit up there for me to ask you this question. What is the best, and Stephen's from Donegal, he's an AP in Donegal, what is the best approach for IV access in very young children?
Very young children. So, very young child, I would assume is less than 1, you think? Neonates are 28 days and younger, so even smaller than that. It is whatever level you're comfortable at. So even you know, I'd be comfortable, let's say, with a less than 1-year-old, but I'd be less comfortable with a 28-day-old. Is that right? So your comfort zone is exactly where the experience you have in putting in drips. By and large, the smaller they are, the less places you have of hitting a big vein. Okay, so in a child that is a neonate, let's start with the smallest. You probably have 3 areas that I would go for if it was an intravenous cannula. One is the dorsum of the hand, the other one is in the elbow. And when you fail, you get out your razor, because you put a scalp vein in. And that to me is actually the easiest place. We've nearly forgotten how to do that now. Most of my NCHDs have forgotten how to put a scalp vein in. Although when I was growing up, I suppose in Harcourt Street, what happened was that if you failed once or twice, you just got the razor out and started shaving away, and you put one in, because it's very, very visible. It's a great place, and it's the same as cannulation. It just looks a bit like Bjorn Borg, you know, that fella. And parents they're quite freaked out about it. So you have to explain to them first, and then they're fine with it. Rather than to poke a child 10 times, go once. That's with a neonate. With a slightly older child, older infant, maybe about 1 to 1.5, you're probably talking about the dorsum or the elbow as well. And some people use the feet. So those are the 3 areas. I think the key point here is not to get hung up in the position. If you tried once or twice and you can't get it, intraosseous. If the child is sick, just go for an intraosseous. Very, very simple. Okay.
Gráinne Ryan in Clonmel has a question. Should we have local anaesthetic cream, as in what the hospital have, or to help to numb the area before you actually, because we don't want to frighten the child, we don't want to make the child afraid of the needle, the big bad wolf.
Good question. So there are 2 mixtures. The one that's been around the longest is called EMLA, which EMLA stands for Eutectic Mixture of Local Anaesthetic. It's been around a long, long time. It takes about at least an hour to work. and it causes some vasoconstriction, so vasodilation, sorry. So quite good, but it takes an hour to work. Amatop, which is the slightly more newer one, it's been around for 5-6 years now, is it? About 5-6 years or so. Takes half an hour to work. And is probably anecdotally better at numbing the area. But look at those times, 30 and 60 minutes. So you have a child that is really, really sick. You don't have 30 to 60 minutes. If you do, you should probably put it in, and maybe the child, by the time the child comes to hospital, we can do something about it. But most of the time, you don't have that 30 to 60 minutes. So the answer is, if you need to put one in, put one in.
Okay. The other thing is that you've got to tape over it. So they're sitting there looking at this thing, knowing what's coming for half an hour or an hour. So it doesn't actually help in that situation. You can get a spray.
A spray is a cryogesic spray, and it's a numbing. It's cold, so basically it's just really, really cold spray. The problem with the cold spray, as you can imagine, I've got very big veins. You know, I'm nice and warm. Suddenly you put really cold spray on it, gone. You know, so that there is a risk of that, but you can use cold spray, yeah.
For those of you, Adrian Murphy has done a lot of work in regards to intranasal fentanyl. Of the APs in the room, have any of these, what's your experience of intranasal fentanyl? Any feedback?
Good. Yeah, I think the last time I had it was a burns patient, but I actually gave Calpol first because I thought at least they might associate this with the pain with the fentanyl. The child slept on the way to hospital.
The first real time I used it was I had a child that had a complete break of the forearm, and when I got there she was in the mother's arms and wouldn't let me go near her at all, and she was really, really frightened. And I gave her intranasal fentanyl, and en route to the hospital she began to sing, "I can't feel my face when I'm with you." It was a bit of a scary moment while the mother was standing there with a mobile phone recording this. Just a show of practice. So for those of you who are wondering about appropriate pain relief, don't hesitate to look for intranasal fentanyl for a young child. It's really, really good. And as I said, Dr. Adrian Murphy from Cork has done lots of research on it and has filtered back to FEC as well.
30-minute turnaround time though for it. So if you are stretching it a little bit further, it'll start wearing out quite quickly.
Pearls of wisdom for us when we're dealing with kids. Just, I don't know whether you missed it the last time. We had our Doc Mac stuffing bag. I had a picture up the last day. Have you seen the Doc Mac stuffing bag? So one of our responders has made up a Doc Mac stuffing bag, and within it she's got Calpol, ibuprofen, and different medications required for kids. And she's saying like it's better to walk in with a child, treat a child with this than to walk in with this big massive trauma bag, because it takes the fear away. So have you any lessons of how to remove the fear of the big Nina coming up? And I mean, look around you, imagine half of these fellas walking on top of the child, you know. You haven't seen much watching what we're streaming to.
Do you know it's really funny. If you are afraid of the child, in my experience anyway, I think gets that vibe and is similarly afraid of you. I just get that kind of feeling. It's not because I've been doing the job for 20 years now, and it's not because I'm getting any more beautiful either. But you seem to be able to go to a child, or I can a lot of the time go to a child, and for some strange reason they kind of smell you. It's like a dog. They smell you a bit differently or something. So I'm not quite sure what it is. My only trick, I think, that I can give you is to have a parent around, and to have that child really, really comfortable with someone that they trust. And it's all about that. It's about gaining the trust of the child, however it is, whether it's with someone that they know, they are comfortable with. It's something like Glenn was saying, do you approach them with a package that is better for them? So I would imagine, certainly, and it's probably the truth, that if that package, she'll be very happy. She'll sing the song for you.
Yeah, she will. Yeah.
You know?
Yeah, obviously we have a couple of CFR groups, but one, the Irish Red Cross down in Cork, have come in and said, what makes it hard to revive a child from cardiac arrest compared to an adult with the same condition, given the child's heart is healthy?
That's true. I think that adults, certainly a lot of them have pre-existing or pre-morbid conditions that may make it a lot more difficult to resuscitate. But don't forget that a child has very little reserve. So I sort of run it like this, that if a child comes in, you know, they're running literally 100-meter race. Everything is accelerated. So you take an infant with a pulse rate of 160, 170, 180, 190 when they're septic and febrile. They can sometimes go over 200 when they're febrile. What happens then, I suppose, is that the myocardium at some point in time is going to stop. It stops quicker because they are running that quickly, 200 per minute. So their reserves are much less. By the time they come in asystole, you know, everything is more or less spent. It's very, very difficult. As I said, doing this 20 years now, resuscitating, I think I've only resuscitated 3 or 4 children. So the outcomes are really, really poor. It's not. I don't think, you know, the cardium. Yes, you're right. They don't have any pre-morbid conditions, but by the time they've come into you, you know, it's spent, so to speak.
Okay. I suppose the same question as Prof Plunkett got. What have you seen things that we could be doing better?
I think
sepsis,
that's a loaded question. Yeah?
Sepsis is a huge buzzword at the moment, and when it comes to kids, we're hearing about children with chickenpox actually getting sepsis, but it's not being identified because people are just too focused on the chickenpox and missing out on the sepsis.
Sure.
So from sepsis in regards to circulation, in regards to kids, is there anything we could be doing that we're not doing now that could help to improve the condition of the child?
I don't think so. I think with you know, like I was saying, it's about the recognition of it. How do you recognize it? You recognize it because you know what you're looking for. And if you don't know what you're looking for, then you're not going to be able to. So that's the first thing. If you know what you're looking for, it's simpler. If you have standards to work towards, that certainly will help too. Because if a child comes in with chickenpox, you score them at a certain point on a chart, but then 20 minutes later you score them again, but hang on, they've gone on to a orange or purple zone or wherever it is, then you know, hey, hang on a second, whatever I'm doing, whether it's giving the antipyretics, analgesia, the fluids, it's still not working. This child is actually deteriorating in front of you, you know. And that comes nicely to the point that Glenn was asking, you know, can we do anything better? I always say to all the APs, you know, it's a bit of a laugh. And paramedics.
Yeah, and don't forget them.
Yes. Emergency medical.
Yes. Pre-hospital
group. The pre-hospital group. It's that, you know, when things are going wrong, I think that we need to be communicating with each other. We need to be, you know, and that's why we've got radios now. I think the radios help a lot, because if there is a problem on the field, you know, I get a question directly from them. Look, we're doing this. I'm not quite sure. The child's deteriorating still. Is there anything else that we should be doing? So certainly, you know, following the Australian system where I was, the consultant on call on the floor had a cordless phone, and you'd be conferenced in when you were retrieving. So any retrieval team that came into Westmead Hospital would be conferenced, and you go through all the ABCs, you go through the treatment modalities they were starting, and it would be myself, probably an anaesthetic, ICU, whoever it was, and you'd be conferenced in. They'd ring you back 15 minutes later and say, we've done all that, something's still not right. There's still deterioration going on. What do we do next? So the main way I think that we can alleviate these things, besides standardised charts, is to keep in contact with each other. I'm not quite sure how.
So I believe, I don't know, my HSC colleagues, because DFB is not in the Tetra network yet. I don't know whether the Tetra network has been opened up to the hospitals with the HSC yet. Initially there was a training issue with regards to the staff in the emergency departments receiving the call. It was different. Are you up and running yet with Tetra to the EDs?
Yeah, it can be through the control room.
Through the control room. So to me, and this is again, as Prof Plunkett would say, at Paddy Plunkett is saying, at Glenn Ellis is saying, that this 3-way or 4-way communication that's going on, I think, needs to be addressed. We need to have a direct link to the, like APs have, and paramedics can access it as well, is medical oversight through medical and call, and we can get, and we're working together. But you're ringing with, I want to do X, Y, and Z. Is that okay? Instead of, can you help me here? What can I be doing different? You know.
Absolutely.
Sometimes you're going to get doctors in the emergency department who aren't familiar with certain drugs we're carrying or that we're not carrying, and say, well, you should be doing this, this, and this. So it's interesting to hear you talk about the inotropes, because it is a buzzword in America at the moment about how the most appropriate inotrope is going to be used. I suppose head injuries. Are you going to deal with head injuries when we're doing trauma?
Yep, head injuries and trauma. Okay, not at the moment anyway. You know, the other things I suppose that are interesting is that you know, giving lectures to pre-hospital care attenders and those when the slightly more advanced ones who are able to give drugs, we still have a few deficiencies in the CPGs. So things are moving along quite quickly. Treatment modalities change, and sometimes there is this disconnect between what is being given at the moment and what we would like to give, perhaps. And I know that that's been addressed too with a little bit of medical oversight, and hopefully we'll be able to look at the new at CPGs and change them.
Anything from the audience, from the PEDS perspective tonight, circulation? Anyone add anything in?
Question there, should we be measuring lactate pre-hospital?
Okay, so the question came in, there's two questions with regards to sepsis. One was, should we be measuring pre-hospital lactate in children? Do you think is it appropriate? And the other one then, the studies coming out with regards to CO2. CO2 is a device we can use. End-tidal CO2 is something we all have in our ambulances now, and we can use it. Do you think that may benefit with the diagnosis of sepsis, or do you think lactate measurement in kids can help towards the diagnosis of sepsis?
Good question. Lactate measurement is good. It's very, very useful in sepsis, and we certainly find that when they come into the hospital. My question, I suppose, is that how are we going to get that in the field?
Well, it's being done in Cork at the moment. Our colleagues
with
Cork
point of care testing.
Point of care testing. Yeah, I think it's an Abbott machine they're using.
Okay.
The iStat.
So iStats have been around for many years. I tried an iStat about 15 years ago. They come in cartridges, and you can, you know, within about 20 seconds, you get that. So lactate is useful. The problem, and same with the other things, is we were saying about the IO needles. A cartridge is probably about €10.
Yes.
Or €20. That child, no matter what the lactate is still going to need resuscitation. You're still going to need to recognize that. You need to start first aid straight away. So if the child is shocked, you're going to need to put a line in. You're still going to need to put fluids in. You know, so it doesn't really matter what the lactate gives you a good idea of prognosis, perhaps, as you go down the line. But as far as emergency resuscitative care, it doesn't make a huge amount of difference, because you have to resuscitate the patient anyway. That was lactate. CO2 devices, in what capacity?
End-tidal CO2, I believe if their measurement is low through the nasal cannula prong, it can be also indicative of your patient. It's another add-on marker to your sepsis markers.
Yeah, so studies have come up from America mainly, not so much UK, that also is a marker. Again, that doesn't really change your management again, does it? I mean, you have a child that needs resuscitation, you're going to give that resuscitation, you're going to give that fluid, you're going to give pain relief, you're going to give antipyretics anyway. All right, so I don't think that should affect you. It will help us certainly greatly in the once they come in. If you can tell me lactate's 6, oh yeah, look, this child is very, very sick, and we can act on it further. But yeah, that's all.
I suppose going back to the Pew score and what Rachel was saying, that 2 or more of the following: a core temperature less than 36, higher than 38.5, inappropriate tachypnea, inappropriate tachycardia, reduced peripheral perfusion, altered mental status, and considered comorbidities. They're your kind of main key things, and the other ones are just nice ones to add on. What I always like about, one of the things, the stories I always like about PEDS is the fact that 2 EMTs got together, a group of EMTs got together from the Order of Malta, and went and done a study in regards to the number of children that they're actually treating at events, and they produced a paper, research and a study in regards to the numbers that they were seeing, and from that then, as part of the EMT CPGs, were able to give ibuprofen, because they're able to prove that EMTs were actually accessing a number of kids. You know, so if you are in a certain body, a certain group, a certain organisation, and you are starting to come near kids, or not come near kids, being around children, treating children, please do try and think about, within your own organisation, a possible clinical audit. You know, go to your training officer and ask them, you are very interested in this, is there any chance you get involved in some type of audit of ACRs, and actually start to combine evidence, because that's the only way you can prove that at the level you're at you need to do more, or you want to do more. Okay? So has anyone any more questions they'd like to add? No? Everyone happy enough? The machine is quiet as well. Okay, so on that, I'd like to thank you all for coming. Take stand. There was somebody in touch with me from one of the centres on Gardiner Street with regards to the identification of meningitis in children. They're going to provide us with a lot of cards. I didn't want to bring them tonight because it's unfair in the satellite centres, so we'll send them out to the satellite centres before the next show, so you'll all get a little card in recognition of sepsis. We're back probably the end of January, beginning of February for our next session. I want to wish you all a very happy Christmas, a very safe Christmas. Hope you all are back. Every one of you can come back here in February to join us. Any feedback, please let us.
Just looking at time there, that's why I didn't.
Yeah.